So I did my law review note, which is a student article for the Yale Law Journal on, it's called The Use of Mechanical Restraints in Psychiatric Hospitals. And I went to one of my professors who was also a psychiatrist and psychoanalyst at the law school and said I was writing my note on restraints and these must be very painful and degrading. And I did not self-disclose, didn't have the courage to self-disclose at that time. He said, "Oh, Elyn, you don't understand. These people are psychotic. They wouldn't experience restraints the way we would." And again, I didn't have the courage to tell him that I had experienced them and that indeed it's just as you or your family would have experienced it. But it was only by kind of, quote, othering us that you could feel okay about having done to people something you would never dream of wanting for yourself or your loved ones. A lot of times clinicians say that patients, or at least many patients, value being in restraints. It makes them feel safe. Well, I have never met a patient who said anything remotely like that, and I get lots of inquiries and calls from patients, but of course I haven't surveyed the whole field, and there may be some people who do like them. And people say even if restraints don't make people feel safe, they keep them safe. But the reality is that each week it's either 1 to 3 or 3 to 5 people die in restraints. They aspirate their vomit, they strangle, they have heart attacks. So it's not really clear to me whether we're saving lives or costing lives by using restraints. There's a lot of evidence that how much they're used depends upon like the head of the ward or the head of the hospital and what his or her views are about this protocol. But it might be better to consult patients and caregivers, as well as the hospital staff who use restraints. In other words, we shouldn't use a top-down approach, but a bottom-up approach, or maybe both of them together would be best. Now in England, where I lived for a few years after college, they haven't used restraints for over 250 years. Perhaps British people are more respectful of authority than Americans are. Perhaps they're less violent. We actually have 20 times the homicide rate that they have, which is probably much driven by how much easier it is to get guns here than it is to get guns there. My own experience was horrible. When I was at Yale Hospital, I was restrained 20 hours a day for 2 days and then 5 to 15 hours a day for the next 2 or 3 weeks. And my chart had this notation, quote, "Use restraints liberally," unquote. Of all the involuntary care I experienced, like involuntary hospitalization and involuntary or forcible medication, restraints were by far the most toxic, and I still have nightmares about them. And there are examples of places that have reduced or eliminated restraints in America. Matt talked about the experience at Emory, which is really wonderful and uplifting, and would love for them to do talks or train trainees about how to get along without restraints. There are 2 cases where there may be some limited use for them. So one would be you're in an ambulance going to the hospital and you might interfere with the driver, you're out of control. But then, restrain someone by one wrist. You don't have to tie them down at 4 points and put a net over them. And another example is where our doctors or nurses need to be by the patient at close quarters to talk and evaluate. But it seems to me that it might be better to have dangerous patients in seclusion and in some kind of box that you can talk through so you can have a conversation, but the person doesn't have to be put in restraints. So my recommendation would be to do our utmost to eliminate, or at the very least, lessen the use of restraints. Maybe we should send psychiatry fellows or psychiatry residents and psychologists to England to spend a semester there and see how they do it, or to the place at Emory where they've gotten rid of restraints. So in other words, upgrade the training that people are getting about how to use these things. In the end, I'd like to say that the way Matt Tuleja describes being treated is nothing short of scandalous and shameful, and that he and I, and I'm sure others treated in this way, stand tall together for change. Thank you.
Now, we are in a particularly interesting setting in that we're addressing psychiatrists from a patient and professor perspective. So, we have here folks that have been under the care of psychiatrists. We have people here who have studied psychiatry in depth. And what I want to know from you, Elyn, is what is the
Mhm.
value of bringing our voices to this space and talking to the psychiatry world or psychiatry force about these perspectives?
Uh, Bringing our voice forward is extremely important. Um, no one understands something like restraints or forcible medication or whatever, as well as someone else who's undergone it. And there's also, if you're connecting with people who have the same experience, there's less stigma. You're both kind of in the same space. From the point of view of psychiatrists and psychologists who are in places that use these, I think the idea would be having people speak out, talking about their experience, talking about the trauma, talking about the toxicity. Um, and as I said, maybe having some people go over to England and train under their system could be an important thing to do. So I think I think it's important to have people with experience talk about this. They understand each other more, and they should be able to give the psychiatrists and psychologists a perspective that they might have. I might add, it goes the other way. So Ken Wells, who's a psychiatrist and a musical guy at UCLA, put on some programs on this, a couple of operas on The Center Cannot Hold My Book. And the first one had me in restraints and forcibly medicated. And it was actually very painful to watch. But the interesting thing was how stressed out the doctor was by having to do this young doctor. And I hadn't really thought of that point of view. I was too focused on my own experience. But I think the whole process can be kind of toxic and traumatic for caregivers as well as patients, which makes it even more, all the more urgent to try to reduce or eliminate their use in psychiatric hospitals.
Yeah, I absolutely agree. And one thought that came to mind was just, whether physicians actually have that similar experience of being restrained or being sedated, will that change the way that they use restraint or sedation? What are your thoughts on that?
That's an interesting concept. My guess is it would make a big difference if someone had actually experienced it and knows what it feels like and knows what it's like.
It does bring up an important thing, which is that the design of restraints and sedation is really for the protection of the staff. And a lot of
Yeah,
physicians are concerned about their own safety in these
yeah.
environments. So, have you considered or have you thought of any ways that, our legal system and our political system and our medical system can work together to create a solution that would be protective of really both physicians and patients?
Yeah, no, that's a really good point. I mean, a lot of the fear of patients is probably driven by stigma. I don't think that that many patients are that dangerous. Uh, but as I was saying, there are ways that we can do this that are less threatening to the caregivers, like by having them talk through a window or instead of actually being in the room with the patient. I mean, there are other things like that we could do that would keep staff safe and patients safe. Um, I mean, I think by and large, the people most often physically hurt by the restraints process are the people who are being restrained, you know.
Right.
But I agree that, there's more people to think of than just the patient, and we want to do something that keeps people safe. I was in a psych hospital in England, but I volunteered after that at a different psych hospital. Um, and there was an occasion where one man jumped another man and pushed him to the ground and started punching him. And what happened was staff and patients took the person off the other person and sat him down, 6 feet away. And the doctor came and sat next to him and said, Joe, that's just not on. You really can't do that here. In America, the person would have been slammed into restraints in the seclusion room and left there however many hours or days. It's a different kind of mentality. And honestly, I think it's better. I mean, there are lots of ways that you can distinguish or compare England and America as an example. They involuntarily commit 3% of their patients. We commit about 50%. They give a lot of people a right to make their own treatment decisions. We take that right away from most people. And again, they haven't used restraints largely for over 250 years or whatever. So it's a much more humane system, it seems to me. And we have a lot to learn, I think, from them and from places like in Emory, where we've done such a good job in reducing the use of restraints.
Yeah, I really wonder if we could learn something from them, and I wonder how we could actually make that happen, who we could collaborate with to bring that type of ideology over here. This is one step that Matt is taking right now. So Matt is taking this step in a way that he can raise awareness of this issue and try to really get help from the folks that he's speaking to. Yeah, so you were telling us about some of the policies that you've been a part of and some of the research that you're doing to try and promote reform. And it sounds like you're asking for your community to really support these changes, especially with that Millionaire Fund project that you were just mentioning. Is that accurate?
Yeah, no, yeah, you heard right. I'm making an effort to address the issues that I think are so important and so needing of being addressed, and educating the public, and also educating, clinicians and mental health lawyers and so on about what the issues are and what the prime or optimal policies likely would be. And basically what both of these things do, supported decision-making and psychiatric advance directives, is that they restore more people to being essentially the architects of their own lives. And as someone who has had choice taken away from her, I can say that that's extremely important.
From me. Now, this audience we're speaking to is mainly psychiatrists, right? So the majority of our audience will not understand the barriers that you face on the legal side of all of this. How can somebody who's listening to you right now be most effective in getting involved with your efforts? Or how can they make the big impact on their level?
Yeah, I mean, I think if they hear what I'm saying and they think it has merit or value, that they would take steps to kind of implement some of the things I'm suggesting, like reducing or eliminating restraints. That would be my hope, that they listen and be more thoughtful about how they use these modalities. I mean, basically, you want to treat patients like anybody else, and that's to say with dignity and respect. They're not lesser citizens. They're not lesser people. They're not largely incapable of making decisions, and we ought to treat them as such, as capable and respected and having dignity.
Absolutely. Matt, just based on the flow of this and how we intend to cut it, I mean, you can ask questions right now if you want, and we can clip them in.
Say that, when I'm hearing you talk about your body of work and you paving a path for people like me to be encouraged enough and courageous enough to step into the space and say, hey, you can't do these things.
Right.
There's a sadness, a root sadness. And it's that, when we conceptualize mental illness, and I think psychiatrists would share this paradigm just as a peer or a patient would. There's so many brilliant and meaningfully contributive members in society who are limited or have a glass ceiling as it relates to being who they could be, because effectively they can't access their right to health, or they can't sustain their best brain health. And much of that comes from barriers, be it parity in finances, be it the misdiagnosis rate, be it compounding trauma that people have to endure when navigating the mental health care system. And I think we both agree that by and large, despite the gauntlet that you and I have both endured to chase fostering and living a life worth living, and working and loving and contributing to society, the most deleterious and harmful and degrading and traumatizing piece was the seclusion and restraint. And I think there's another layer of that, which is prejudice and bigotry and hate, really, that some professionals carry. You know, you mentioned there's some folks along the lines of the musical that you mentioned, that they feel sad as they should, they feel upset as they should when they have to use these limits. But what I've found in my lived experience is that that's not always the case. And that's absolutely abhorrent and inexcusable. There's people who laugh, there's people who clap, there's people who use excessive force and brutality. And I read about that in your book. And I think when I hear about Elyn talking about different practices and protocols that can be implemented, a rights-based approach seems absolutely necessary. This systemic disease, if you will, is harming those things. It's harming our ability to feel safe when accessing healthcare. It's harming our ability to have our healthiest brains. The Hippocratic Oath is, but first do no harm. So why is it that there's been practices in place for such a long time that are avoidable, that cause so much harm?
Matt, I think connecting with you and bonding with you has been extremely important to me. I think nobody understands as well, as I said, as a fellow sufferer, and that we both have a lot of the same values, hard work, doing well, and trying to be kind. And, I consider you one of my closest friends now, and it's just been a real gift to have you in my life. So thank you.
Yeah, that means a lot to me, because the journey of restoring human dignity after you've endured something like that is not easy. And I think the last thing to wrap up would just be that there's a lot of people like us, right? The whole idea of Matt's mission is not about Matt, and it would serve peers, survivors, as they come out of the woodworks, as teammates, mothers have called me, said, hey, me too, to organize our voice in a way that's going to be powerful and effective in the space. Because to some degree, some of these abhorrent practices, we're not asking for you to cut those out. You really have no right to be abusing or torturing a patient. Right. And I think we as a field need to have some discussions about organizational leadership and following practices like Sam Jackson's colleague, Dr. Cody, implemented at Emory in Atlanta, such that that becomes a standard and anything else is unequivocally malpractice.
Yeah, below the standard of care. I mean, I sometimes say that people coming to see mental health disorders as brain disorders doesn't much reduce stigma, but putting a human face on does. And you are a human face, Matt. You're a collegiate football player, and have Matt's mission and all the great works that you do. So that's going to help reduce stigma, I think, and hope.
The group of people who have come to support, including you, Elyn, have been some of the greatest gifts I could have asked for in terms of teammates that are going to help accomplish this mission. So I just want to say thank you so much for taking the time. And
thank you for doing what you're doing. I mean, it's amazing. It's great.
Hopefully that is something that psychiatrists carry in the front of their mind and consider when stepping into crisis intervention, so that they can de-escalate, and so that the stuff that I went through and that you shared that made me cry doesn't happen to another patient. Thank you.
Thank you.